All right, we might as well get started, I think, on our last grand rounds of 2022. I appreciate this great attendance for this almost holiday season, or this definitely holiday season. And you won't be disappointed, I will tell you. We have the privilege today of hearing from Dr. Tiffany Walker, who's an assistant professor in the Division of General Internal Medicine and who practices at Grady. Dr. Walker graduated from MCG from medical school, and then we were lucky to recruit her as a resident in our program here at Emory, where she was subsequently then chief resident. After that, she applied to and was accepted to and joined CDC as an Epidemic Intelligence Service officer in the National Center for Emerging and Zoonotic ID. She participated, among other things, during that time in the Ebola response in Africa. And then spent, after graduating from that program, spent a couple of years in New Zealand as an epidemiologist for most of that time before returning happily to Grady and taking a position as a faculty member, and has been really an incredibly highly regarded teacher. But while doing that, she has also been busy in other areas. She co-founded the Grady Post-COVID Clinic and co-established a multi-site long COVID registry and biorepository. She currently serves as a sub-site co-PI for the Recover Initiative, which we're going to hear about, I assume, a large meta cohort investigating the natural history, pathophysiology, and identifying effective treatments in patients with post-acute sequelae of COVID-19. And I'll say that this work will inform us about COVID-19, but it also, I think, it will lead to an incredible amount of discovery about the pathogenesis and pathophysiology of viral infections and many other aspects. And so I think this is work that will have many lives beyond, including and beyond the COVID pandemic. So Dr. Walker, Tiffany, I'm really excited to welcome you and to hear your talk today.
Excellent. Thank you so much, Wendy, for inviting me and team as well. And thank you, everybody, for joining me on this discussion of post-acute sequelae of SARS-CoV-2. You'll hear me refer to this as PASS through most of the presentation, but you'll also hear me refer to it as long COVID. The term that's more common to you all and is a term that's actually coined by a long COVID patient is an important term to use in that population. So this is largely the silent pandemic. These symptoms can be quite disabling for some patients, and I think it hasn't received the attention it really warrants. I hope to impart on you all that this will impact your clinical practice, and you will be seeing these patients as we discuss this. So our learning objectives, I'd like you to be able to describe past epidemiology in terms of where we're at with the literature currently, identify past symptoms and characterize the impact that it has on daily function and quality of life, and to characterize past physiology based on the current research, describe diagnostic and management approaches to treating these patients with long COVID. So I'll start with a past case. So this is a common presentation in our clinic, but I want to underscore that this is a really heterogeneous disease. So there's not one typical past patient. I get asked that a lot, but this will give you an idea of one of the types of patients that we do see. So this is a 52-year-old female with obesity. She is fully COVID vaccinated prior to her incident infection. She is presenting 6 months after that infection, and she has a chief complaint of fatigue and forgetfulness. In terms of her fatigue, she mentions that it's really worse at the end of the day. She notices it more so if she's had a really hard day at work or if she's exerted herself. And these symptoms can last for days to weeks, and then maybe they'll get better over time and then come back again. So it kind of waxes and wanes. She has problems with her memory. So she's finding that she's very forgetful. She's an attorney, and so this is really impacting her ability to do her job. She was previously very good at multitasking and concentrating, but she's noticed that those have really been impaired as well. She has headaches that occur about 3 to 4 times a week. Some of them are somewhat mild, other ones are quite severe and can also impact her ability to do work. When you ask her about it, she says, yeah, actually, I have had trouble with sleep. I have trouble falling asleep as well as maintaining sleep. Wake up a couple times at night and have trouble falling asleep again. This makes her pretty sleepy throughout the day. You do a workup with physical exam and basic lab tests, and you find the only diagnostic abnormalities are that she has a reduction in her digit symbol substitution test. And this is a test that we do in our long COVID clinic at Grady that was recommended by our neuropsych colleagues. And this is a measurement of concentration and processing speed, and it's impaired in this individual. And she has an elevation of her D-dimer to 980. Otherwise, the workup was normal. And we'll come back to this case as we discuss long COVID throughout the presentation. So what is long COVID? This is a hotly debated topic. There is no definitive case definition at this time, but the WHO through Delphi consensus has put forward a case definition of an individual who has a prior SARS-CoV-2 infection, who has symptoms for at least 3 months from disease onset that last for at least 2 months. The reason they have this caveat is because in some rare cases, you might actually have a patient who is asymptomatic that then goes on to develop new symptoms consistent with long COVID. But the important time point to remember here is symptoms lasting at least 3 months. And they can be new onset since recovery, or they can be persistent. So some people, their acute COVID symptoms improve, but then they start to come back again, or they may have new symptoms, or these symptoms could just be persistent since acute onset. Importantly is to point out these symptoms may fluctuate or relapse over time. And I want to highlight this because sometimes as clinicians, we might discount someone whose symptoms that aren't consistent or consistent with the diagnosis we're familiar with. If they had parenchymal injury, we would expect that they would have a persistent dyspnea. But we find that actually in these patients, their symptoms can relapse or remit over time. And there may be some explanations outside of end organ damage that contributes to this. These symptoms cannot be explained by an alternative diagnosis. So you may have a patient who has COPD and has shortness of breath, but they notice after COVID that dyspnea is much worse. And I find that they are usually able to discern the difference. So new or worsening symptoms from COVID onset, and that these typically will impact a person's everyday functioning. The best reports that we have for incidents come out of CDC. There's an MMWR article that was a EHR retrospective cohort study looking at about 300,000 infected controls compared 5 to 1 with, 300,000 cases compared 5 to 1 with controls. And they found that there was an absolute risk increase of about 21% in the working age adults versus 27% in the older adults. So this corresponds to about 20 to 25% of COVID survivors going on to develop long COVID. And that's substantial, right? Because this is our epi curve of US cases. And you know that we're approaching 100 million cases in the United States alone. And that's just what's being reported on the epi curve. We know that this is largely an underestimate of the number of cases that we have, which are primarily PCR tested cases are reported. So those that go untested, as well as since the advent of at-home antigen testing that started at the beginning of the last winter wave, a number of those cases are not getting reported as well. And so that's also represented in the percent positives. So we saw in the summer wave, the number of cases here that are being reported on the epi curve are very much an underestimate, because the number of percent positives in this wave really approached the previous winter wave, which in and of itself was a huge underestimate of the number of cases we're experiencing. And why do I talk about acute COVID? The more acute COVID we have, the more long COVID we'll have. And that's represented here in the figure on the left. This is from the American Academy of Physical Medicine and Rehab. And they're estimating, based on these previous incidence estimates, approximately 29 million cases of long COVID in the United States alone. And if this is accurate, this would correspond to approximately 840,000 cases of long COVID in Georgia. So this gets back to how this will impact your clinical practice. This is 840,000 patients potentially that have a new disease that didn't exist 3 years ago. And this really overwhelms the system we currently have for long COVID specialty clinics, because we can't manage that burden. And I know in the Emory system, we often have wait times greater than 4 months to get into long COVID. And I've heard other colleagues in long COVID clinics across the United States having wait times greater than 8 months to get into these clinics. So I think one of the drivers of giving this presentation today is to underscore the importance of decentralizing long COVID care and bringing it back to the primary care physician, which I know is somewhat daunting, but hopefully I'll give you some tools that will equip you for caring for these patients, because it's a pretty substantial burden on the healthcare system as it stands, and certainly cannot be managed by long COVID clinics alone. So let's dive into the symptoms of long COVID. What does it look like? And let's characterize the impact it has on daily function. So this is a meta-analysis of 18 studies, 9,000 people, and this gives you the idea of the symptoms experienced by long COVID patients at a 1-year time point. So pretty late. 1 year from incident infection. And we find that fatigue is the most common. I think that won't be a surprise to anyone, but fatigue may not just be continual fatigue. Consider like our case patient, potentially post-exertional malaise. And that's an individual that may be able to exercise or do a hard day's work, but has a delayed onset and just crushing fatigue or malaise similar to having flu without URI symptoms. And so these can last for quite a long time. So this may be heterogeneous even within this, and post-exertional malaise is something that is coming to the forefront, but has not been investigated well in previous studies. Depression and anxiety are quite common and may actually becoming more common later in the disease. When I talk to patients anecdotally, they say they think that this depression and anxiety is mostly related to the disability they're experiencing from these other symptoms. Symptoms they didn't have before COVID that have really impacted their quality of life. Brain fog is quite common, and I think it's becoming more familiar to providers. Although it wasn't well characterized early in the past literature, this is trouble with concentration, trouble with multitasking, word searching, so language issues, processing speed. Those are the common things that are affected in brain fog. Dyspnea, quite common, as you'd imagine, but again, some of this will have to do with parenchymal injury, microvascular injury, but some of this will be perceived dyspnea related to other underlying causes, which we'll go through. Sleep disturbances is something that we're just starting to clue in on. This is trouble falling asleep, trouble maintaining sleep, or unrefreshed sleep. But also there's a signal for potentially new onset sleep apnea, which is being investigated further. A patient may just present to you with pain syndromes, so joint pain, muscle pain, nerve pain that wasn't investigated in this study, but we do see. And then chest pain and headaches are common. Anosmia, as you're familiar with, and then palpitations and dizziness, so sinus tachycardia that's not otherwise explained. And then these two may go together, palpitations and dizziness, and we'll cover that as well. It's important to mention the disability. So there's one study of 4,000 long COVID patients showing that at a 7-month time point, 50% were unable to return to work at full capacity, and 25% were unable to return to work at all. And that was at 7 months. So again, to underscore how disabling this can be for some patients and how that will impact your practice. This is a study out of CID recently, and it shows one cohort of patients over time. And I think it's a good way of looking how symptoms may trend over time. And we'll walk through this. So some of these acute viral symptoms of fever, sore throat, vomiting, diarrhea, quite common in the early phase and really resolve later on. And we don't see them to be common manifestations of long COVID. However, the dyspnea, quite common in the beginning, really remains pretty persistent over time. The fatigue, quite common in the beginning and improves a little bit, a little less common at 5 months, but arguably may be becoming more common at 12 months. So are we seeing potentially somewhat of a curve here where symptoms may actually become more common over time, which is really concerning and needs to be investigated further. Some symptoms not investigated in this cohort in the acute phase, but were shown to be quite common in the later phases: reduced exercise capacity, brain fog, so those concentration, difficulty finding words, and then also sleep disturbances, quite common in these later phases. Some other symptoms that are common in the acute phase and seem to improve somewhat, but are still persistent: headaches, vertigo and dizziness, anxiety, and then those pain syndromes, the muscle, joint, nerve pain. And then I would mention for headaches, these yellow blocks right here that make it look less common. These are comparing males to females, and we do know that males have less persistent headaches compared with females. But if you were to remove those, you just notice the trend over time. These symptoms are still quite common. So the next natural question is, okay, so this is a very heterogeneous disease. So is this one syndrome, or are there multiple phenotypes of long COVID? And if so, are there multiple pathophysiologic processes contributing to these phenotypes? And the answer is we don't know. We don't know what the phenotypes of long COVID are, but yes, it does appear, at least to many of us past providers, that there are likely different phenotypes within long COVID that need to be defined. And there's one study that's aimed to do that. And I'd like to discuss these with you because I think it's quite interesting. So we'll start with cluster 1. And before I do that, I'd like to mention, interestingly, this study is one of the few studies we have that have looked at actual phenotypes in long COVID, and it is a study that was conducted, designed, and published by patients. So this is the Long COVID Research Collaborative, patient-led research collaborative, and they have published a cluster analysis. They have a number of individuals that have familiarity with modeling and machine learning, and they put forth this paper. So the first cluster you'll see on the left is the symptoms that trend over time. And you notice that in the acute phase, those symptoms are common. It seems to rapidly improve and stay resolved. And these are the symptoms that are commonly seen in the acute viral symptoms, much like in the previous CID study. So the diarrhea, the loss of appetite, vomiting, sore throat, and fever. The next cluster, a little more concerningly, you have a lot of symptoms in the acute phase seem to actually get worse by the 5-week period, improve somewhat, but don't really change substantially from the baseline acute symptoms. And the symptoms that stand out to me here are the fainting, the chest pain and tachycardia, tightness in the chest, dizziness, the headaches, problem sleeping, shortness of breath, and fatigue. And the reason why these stand out to me is this seems to have some overlap with dysautonomia, or POTS, postural orthostatic tachycardia syndrome, which I think you guys are familiar with. And the common symptoms there, you see the overlap: the dizziness, the fatigue, the dyspnea, the brain fog, the sleep disturbances, and headaches are common manifestations of POTS. This is somewhat of a low data zone right now. There are some small cohorts showing POTS overlap in long COVID patients. But this is a very popular area of research right now. I think we'll be seeing more coming out in the next coming months on this topic. And anecdotally, it seems that this may be more common in the female population, and then also potentially in the younger population. So the 20-year-olds, the 30-year-olds that unfortunately we all felt had a very low risk of acute COVID sequelae, which is true, but are then going on to develop some pretty disabling disease. That can be quite difficult to manage because unfortunately POTS falls into one of those categories of a disease that hasn't gained a lot of interest from the scientific community. So there's still a lot we don't know about POTS, and it in of itself appears to potentially be an umbrella diagnosis with multiple phenotypes. The third cluster, also quite concerningly, symptoms in the acute phase seems to get worse by 5 weeks and then plateau without much improvement. So particularly concerning, a disease state that may persist for quite a long period of time. And the symptoms that are common here that really stand out to me, so skin rashes, new allergies to drugs and medications, the pain syndromes of joint, muscle, nerve pain, the brain fog, and the post-exertional malaise, so that delayed onset fatigue after a mental or physical load. And the reason why these stand out to me is it seems to have a fair amount of overlap with ME/CFS, so myalgic encephalomyelitis chronic fatigue syndrome, which you all may know more commonly as chronic fatigue. It's yet another disease that unfortunately hasn't gained a lot of interest from the scientific community. We don't know much about the natural history, the mechanism, or potential treatments for it because there hasn't been much funding or interest. And that's unfortunate because if we do find that there's a fair amount of overlap between this and long COVID, we could have been a couple steps ahead. So there are major and minor criteria. 3 out of 3 major, you require reduction in previous activity level, post-exertional malaise, and unrefreshing sleep. And then minor, you have cognitive impairment and orthostatic intolerance. So you can see some overlaps there. And so again, this is a defined cluster of long COVID, but it's a potential cluster that people are very interested in investigating further. And the patient advocates who have ME/CFS have really been the ones that have sounded the alarms. Hey, this looks a lot like long COVID, and long COVID looks a lot like the disease I have. So more to come on this. As you can tell, a fair amount of overlap between ME/CFS and POTS as well. So I think it's important to touch on risk factors, which I think we still need a lot more data on, but it's important to know who's at risk for long COVID. So it stands to reason that those who had severe acute COVID would go on to develop long-term sequelae of COVID and more severe PASS. But that's fairly equivocal right now. I think we need more studies. There are multiple studies showing no difference between these populations. And there are some studies, some more robust studies, later time points with multivariable analysis and adjusted analyses showing that severe COVID is more likely to go on to develop more fatigue, chest pain, anxiety or depression, and dyspnea. And then out of our group from our registry and biorepository at Grady, we actually found some contradictory evidence that maybe those with mild COVID go on to develop more fatigue, brain fog, headache, dizziness. So some of the really common symptoms of long COVID. A couple theories behind that. There was a signal for remdesivir. So the question is, if there is a persistent viral reservoir, are those with severe COVID getting treated and potentially eliminating that reservoir compared to mild patients that receive no treatment? Or are the immune responses between severe and mild different and their impact on viral reservoirs? So an area that should be investigated further. But it is important to discern these differences because the majority of patients will develop a asymptomatic or mild infection. And so if those patients are fair game or more likely to develop long COVID, that's really quite concerning because that's, again, a broad swath of the population. One risk factor that's a little more clear, females do seem to have a higher risk of anxiety, fatigue, hair loss, headaches, sleep impairments, concentration, brain fog, palpitations. But I do think we would still benefit from meta-cohort data as these are still somewhat small studies and limited data. And then I think there's really insufficient data on some other clinical risk factors like age. There's contradictory data on these as well as comorbidities. And then surrogates of social determinants of health, diverse populations, education, neighborhood. I think we'll have more data on these once we have meta-cohort data. So let's switch gears and talk about past physiology based on our current research. So interestingly, there's some evidence for potential break in immune tolerance. So there's a paper that came out of our group that was published in Nature recently, led by Matt Woodruff, Anyang Lee, and Iñaki Sands. And we demonstrated that there was increased autoimmunity against multiple autoantigens. And this was particularly in the severe acute COVID population, and that this autoimmunity improved over time in many. And when we repeated the assays on a group of past patients greater than 100 days from incident infection, we found that 35% had ANA positivity and 25% had anti-CAR-P positivity. And so it wasn't 100%, and it would argue that potentially, like we discussed earlier, there may be different underlying mechanisms relating to different phenotypes in long COVID, but still concerning findings that we're investigating further in a dedicated past study that is with reviewers at Nature right now. And so another interesting theory, an alternative or potentially interlinked theory, is persistent viral reservoir. So you can swab the nasopharynx and see no persistence of SARS-CoV-2, but it could be detected in a gut biopsy up to 4 months post-infection by PCR in one study. And then another study more recently that's gained a lot of interest is persistence of spike antigen in peripheral blood detected up to 12 months post-infection, specifically in patients with long COVID. And you see that here in this figure. On the y-axis is the spike antigen, on the x-axis is the months post-diagnosis. In the gray, you see those without long COVID. In the red, you see those with long COVID, and you see a certain percentage do not have spike antigen production, and then another large percentage does. And much like the previous slide, it argues that potentially there are different mechanisms in different patients that might be driving long COVID. But the persistence of spike antigen production is also supported by other papers that show dysregulation of immune responses. So there's some that show upregulation of CD4 and CD8 T cells at later time points that are specific to SARS-CoV-2 antigens. And also there's some showing at later time points waning of CD8 populations compared to uninfected controls, indicating potentially fatigability of the immune response in relation to persistent antigen exposure. So this is an area of significant interest right now, especially for developing biomarkers, both diagnostic biomarkers, since it's a pretty heterogeneous and vague disease, but also surrogate biomarkers for clinical trials so that we can trend responses to treatments over time. Again, because this is a disease that can wax and wane, and it's hard to determine whether they are just relapsing or remitting, or if they're having a response to treatment. So biomarkers is a particular interest right now. But what does this have? What impact does this have on pulmonary function and function on the organ level? So we'll start with this figure. I will explain the table to you. On the left, you have the time since incident infection. In the third column, this gives you an idea of the breakdown of COVID severity in their incident infection, and then the remaining columns are the pulmonary function. So at 1 month, notably, a fair amount of the population is experiencing reduction in their diffusion capacity, as well as respiratory muscle weakness. And you'd expect respiratory muscle weakness if they're on the ventilator, but the majority of this population was mild, so it's a pretty high percentage. And then in another population at 3 months, you continue to see reduction in diffusion capacity, although it's somewhat improved. This study did not look at respiratory muscle weakness, but another one at 4 months showed there was still a pretty substantial amount of weakness in a mild population. But at 6 months, and this is the same cohort at 6 and 12 months, a fairly severe population. So they had a fairly high percentage of DLCO reduction. But even when looking just in the mild population, a fair amount of diffusion impairment, about 20% in the mild population subgroup analysis. So really pretty significant even at 6 and 12 months. And that's what we're seeing on imaging as well. So this is that same study at 6 months. And it showed 50% of patients, even those that had mild acute COVID, were experiencing changes on their CT scan at that time point, most commonly being ground glass opacities and irregular lines. So not necessarily fibrosis in these patients, but still some evidence of impairment. And I will note that this was the alpha strain, so potentially more severe pneumonias in this population. We need more data on subsequent strains, but consider that you will expect to see a certain amount of actual parenchymal microvascular damage in these patients. So there's a lot of interest in thromboses as well. We know this is a procoagulable state in the acute phase, microvascular changes that promote thromboses. And so the question is, are these patients at higher risk of VTE-PE? So the study on the top is that same study from the MMWR from CDC that defined incidence. And they looked at acute pulmonary embolism and noticed higher rates in infected patients versus uninfected patients, and both the working age adults as well as the older adults. And this is corroborated in the study below, which was that meta-analysis we talked about of 18 studies, 9,000 patients at the 1 year time point. So at 1 year, we're seeing patients that are having excess burden of pulmonary embolisms, deep venous thromboses, and superficial vein thromboses. So yes, in the subacute and chronic phase, we do see more VTE-PE in this patient population. These studies also investigated cardiovascular sequelae. And so you see that there are higher rates of cardiac dysrhythmias, so most commonly being atrial fibrillation. But I'd like to also point out sinus tachycardia in that patient who has had COVID and they have an unexplained sinus tachycardia. I often see low 100s, and the workup is otherwise normal. You can consider sinus tachycardia related to COVID. Also consider your POTS population, dysautonomia contributing to that sinus tachycardia. But also you can see bradycardia, ventricular arrhythmias, and atrial flutter. But I would highlight that sinus tachycardia because I've seen that a number of times. Higher rates of heart failure with a pretty substantial excess burden. Higher rates of acute coronary disease, myocardial infarction, ischemic cardiomyopathies, and higher rates of pericarditis and myocarditis. One thing I'd point out, these are statistically significant, these are concerning, but these incidences are not so substantial that you would necessarily work up all of these patients in all patients. I think about this often as an HIV/AIDS population that's a pro-inflammatory state. They're more likely to go on to develop cardiovascular sequelae, but you wouldn't work up ACS in all patients. And so you would use your clinical acumen in managing these patients. And I would suggest that as well, just keeping in mind that there's higher rates of these sequelae, but using your clinical suspicion to work them up. There are a couple of studies that have investigated the cognitive domains that are impacted in those that have brain fog. And these are really tiny studies you see here. There will be more data to come, but at a 3-month time point, we saw that attention was impaired, language, so again, word finding difficulties, memory, particularly short-term memory is impaired. And then at 5 months, similarly, attention, processing speed, and executive function. And then one last study that was a nested cohort and online IQ test that found spatial planning problems and problem solving, but did not find memory. And the question with memory is it truly memory or is it attention and concentration? Because you have to be able to attend to something to then be able to store it in your short-term memory, and whether or not that's truly impacted. In this figure on the bottom, you see the digit symbol substitution test that I mentioned previously. So this is just a matter of subbing in the symbols for the corresponding numbers. And this is something that we do in our long COVID clinic to measure processing speed and attention. So interestingly, in our registry, our Grady population, we had a subset and we looked at those reporting brain fog and their impairments and found that 60% that were reporting brain fog actually had impairments on their digit symbol substitution test. But even more interestingly, 40% that reported not having brain fog actually had impairments of processing speed and concentration. So it underscores the importance of also screening for these diseases. And brain fog, just for a side note, was not just a dichotomous, do you have brain fog, yes or no? We actually provided administered the Promise Cognitive Scale, which teased out things that people are able to do in their everyday life or not able to do based on brain fog. So those that did not feel that they were being impacted actually had some evidence of clinical cognitive impairment, which is quite interesting. Patients that have neuropathic pain, those that have evidence of dysautonomia, there's a tiny pilot study that had some pretty interesting findings. 17 patients with these symptoms underwent skin biopsies, autonomic function tests, and electrodiagnostic tests. 60% of them were found to have evidence of small fiber neuropathy. So this is something that will be investigated more in subsequent studies. So we'll discuss the diagnostic and management approaches to long COVID. And I'll mention that towards the end of 2020, we were recognizing long COVID and starting these clinics. We were familiar with the acute sequelae of COVID, the new onset heart failure, ischemic disease, the thromboses. And so it really somewhat warranted $1 million workup because we weren't quite sure what we were going to find and what was causing these symptoms. And then CDC got a group of past providers together and discussed what is working, what's not, what are we finding, and came up with expert guidelines. And those are posted on their website. So we'll walk through them. They haven't been updated recently, so I'll give you my thoughts based on my experience caring for these patients. So CPC CMP makes sense. Inflammatory markers we were getting on everybody in the beginning. They will be elevated in some, not in others. It will not discern between long COVID. It has unclear clinical utility right now. We might find that there is an inflammatory phenotype of long COVID that may respond differently to treatments than others. It may have utility at that point, but I don't know that trending over time right now makes sense. Thyroid function and vitamin deficiencies are good reversible causes of brain fog fatigue, makes sense to work up further. This is a different slide. These are specialized diagnostic tests you could consider based on your clinical acumen, like we were discussing before. So you will get those patients coming in with joint pain, muscle weakness, muscle pain, and unless they have active synovitis, arthritis, myositis on exam, it doesn't make sense to do a full rheumatologic workup in these patients. Coagulation disorders, this is much like your malignancy patient that's pro-inflammatory state. They will have an elevated D-dimer and you'll have to decide what you're going to do with that. So questionable clinical utility. If you have concern that your patient has an active PE, you'll probably move forward with the imaging. We tend to do VQ scans in these folks because we find they tend to be more subacute chronic PEs and not large, massive or submassive PEs. Troponin is another one that will oftentimes be elevated in your population of unclear clinical significance. And then you're left with an elevated high sensitivity troponin of 30 or 50 in your patient in a outpatient setting, which is never a fun thing to work up further. So yeah, if you think this patient has ACS, they would probably be managed in a more acute setting. Otherwise, the troponin has questionable utility. BNP, if your patient is presenting with symptoms and signs of heart failure, it makes sense. Otherwise, I wouldn't get it on all patients. The assessment tools can be helpful, especially if your patient's in the waiting room before they see you, and can be screened for anxiety, depression, and PTSD. These are all quite common. Helps you diagnose this and trend them over time in accordance with any treatments that you're providing. Other tools, the 6-minute walk test we find useful. A lot of you won't have capacity for this in your clinic, but it can be done in the PFT lab. I have revealed exertional hypoxia in more than one situation from our clinic and had to start patients on HOMO2 from clinic, which is challenging. Tilt table test, consider for that dysautonomia patient, the one that gets up and moves around and is just really short of breath and feels like their heart is racing, they feel dizzy. You could particularly consider it in the younger folks and in the female population, but I wouldn't limit to just that population. We'll see this in other patients as well. And the other thing I'll mention, we went over pulmonary function tests and CT scans. In our clinic, we tend to do pulmonary function tests in people that have persistent dyspnea, especially given the literature. Oftentimes you'll find some new deficits, and CT scans in those that have had a history of a multifocal pneumonia on CT to see if there's any subsequent changes. Sometimes you'll pick up an organizing pneumonia in these patients that can be treated, although I think those were probably more common with alpha delta. Some of these patients you'll pick up bronchodilator response and can be treated with bronchodilators. So management, I think this is a part of the talk that you guys are all probably quite interested in. How are we going to manage these patients? And unfortunately, I'm going to be the bearer of bad news that there's not a lot that we have in our arsenal currently. There are no large clinical trials to date in long COVID. However, there are some things that you can do that are really quite impactful for the patient. So it's very important to validate your patient. A lot of these patients have already seen a physician who has done a good workup and tried to provide reassurance to the patient. And essentially they say, well, I think it's just COVID. It takes a while to get over it. Your workup is normal. Everything looks good. You're okay. And despite that reassurance, it's actually quite demoralizing for these patients because some of them are pretty disabled from their symptoms. And this is a new experience for them. And to be told that they're okay is actually quite scary for some of them. And there's a fair amount of frustration with the scientific community, with the medical community right now. So I would advise saying, well, this sounds a lot like long COVID. This is something that we don't know a lot about yet, but we're really learning a lot about it, and we should know more in the months coming. There are large studies that are providing us important information, and there will be clinical trials that will hopefully find some medications that can be helpful for some patients. But I acknowledge that this is a real disease and something that can be really challenging to deal with. I think credit where credit's due. As I mentioned before, the patient advocacy groups, some of which I've listed here, have been a major driving force behind the research, as well as the awareness of long COVID. Many of the individuals in these groups sit on committees in some of these large studies, one of which that I'll discuss next. And these can also be excellent support groups for your patients. Sometimes, again, just the validation can be very helpful. Some of these patients can go on to these online groups and say, hey, I'm having a lot of trouble with my teeth. Has anybody ever experienced that before? And just hearing that other people have been experiencing teeth issues since onset of long COVID really goes a long ways and really creates a community for these individuals. So consider referring them to these as well. I will leave you with some thoughts on management. So a couple medications that are being trialed in long COVID clinics. It's very important for me to mention these are off-label. They are not FDA approved, they are off-label. But these are medications that we've tried, histamine receptor antagonists, so just H1, H2 blockers. There's some evidence to support that it may impact the regulation of cellular immune mediators, so VEGF, TNF-alpha, interleukins and interferons, dysregulated T cells. And there's one small study showing 70% improvement in symptoms in those that were treated compared to 26% spontaneous improvement in those that were not treated. So that's pretty excellent, right? In a medication that's over the counter that's extremely low risk. So this is a medication that you can consider in your patient population. I'm sure your next question is, what is the phenotype that this works in? The answer is, unfortunately, we don't know yet. But we have found some benefit similar to these numbers in our population in the Emory system. Another medication I'll mention, low-dose naltrexone. So this is an anti-opioid. We find that at lower doses, it has less effect on the opioid antagonism, but it seems to retain some immune modulatory effects, including regulating natural killer cell activation, disrupting signaling cascades that ultimately reduce TNF-alpha and interferon beta synthesis. This is a medication that has been trialed in the ME/CFS population, so it makes sense to use in a similar phenotype in long COVID in small clinical trials with some benefit. And this is being used in other long COVID clinics in the United States, not within our system, but others that I work with. These two medications we're interested in deploying in a pilot clinical trial that I'll be leading early next year as a decentralized telemedicine-based trial that has the advantage of being able to employ these low-risk repurposed medications in a decentralized way. Anytime I'm talking about Recover, I think it's, long COVID, it's very important to discuss the Recover initiative. This is the study in long COVID. It has the support of Congress and NIH. It is funneled through the NHLBI. This defines the natural history, risk factors, pathobiology, and treatments for long COVID. It is a massive 17,000 person meta cohort that was erected quite quickly, which as far as I'm aware, there's really no precedent for erecting a study quite this large that answers all of these questions so quickly. There are 30 geographically distributed hubs and 96 sites across the United States, so we can have a representative sample of the population. We do have a site, a hub here in Atlanta, led by Ego Afotikun, Rachel Patzer, and Priscilla Pemu. I lead the Emory at Grady site along with Jenny Hahn. We have an Emory at Hope Clinic site led by Xanthia Wiley, a Morehouse site from Priscilla Pemu, VA by Sushma Cribbs and Vince Marconi, and a Kaiser Permanente led by Jen Gounder. Very collaborative experience working together as one team. And we collect comprehensive surveys. We collect specimens for a biorepository. This is where we do our translational science so we can identify the underlying mechanisms of COVID. and long COVID, we do triggered testing. So based on how you respond to a survey, you may go on to additional diagnostic tests and imaging, and then clinical trials are currently under development. This is our calling card. This is our QR code right here. You can scan this. We are actively enrolling patients. So please, if you have any patients you think might be interested in the study, we are accepting anyone with exposure to COVID. We have closed our enrollment for controls that were uninfected patients, which honestly is becoming less and less, unfortunately, as time goes on and COVID becomes quite prevalent. But please consider us. I can leave this behind with the administrators. So broad swath summary, the epidemiology of long COVID still is not clearly defined, but it could affect up to 20 to 25% of COVID survivors, which is a substantial number of people and a huge burden on the healthcare system. Some of these will have mild symptoms, but some will have pretty disabling symptoms. Common symptoms to look out for, that fatigue, but don't forget about the post-exertional malaise, that delayed onset after a cognitive or physical load. Dyspnea may not just be from parenchymal injury. This could also be related to POTS or other physiologies, the brain fog, so word searching, problems with concentration, problems with executive function, multitasking, sleep disturbances, so problems falling asleep, maintaining sleep, and unrefreshing sleep, but potentially sleep apnea as well. The pain syndromes, muscle, nerve, joint pain, the hair loss. If you see dizziness and palpitations, consider dysautonomia in your population and screen for anxiety, depression, PTSD. The underlying pathophysiology could have something to do with autoimmunity, plus or minus viral persistence. But we do see that there are evidence of end organ damage that may play a role into the phenotypes as well. So there are likely multiple path phenotypes. I don't want you to come away thinking ME/CFS and POTS are the only, but those could play a role, and there should be more on this coming out soon. Your workup should be guided by your clinical suspicion, keeping in mind that there are multiple organ sequelae. But let your clinical acumen guide you, and then please validate your patients. One of the best things you can do for them right now, get them hooked up with support systems. A big thank you to all the teams that I've been working with at Emory, Grady, Morehouse School of Medicine, on the various studies that I've been involved in. A lot of excellent work. I've learned a lot from everyone, and it's been a really collaborative experience. So thank you to everyone. And these are my references. Happy to take questions.
Thanks so much, Tiffany. I think you're going to have a lot of questions. So I will troll the chat for you. So, and add in some of mine if we get time. Any evidence that early treatment with Paxlovid or molnupiravir lessens the risk of long COVID?
Yeah, so there's been a couple of studies looking at certain medications that might decrease the risk. Some of the studies were more so in medications like fluvoxamine that showed a decreased progression to long COVID. There haven't been quality data looking at Paxlovid yet, but like I mentioned before, we saw a signal in our study for remdesivir treatment in those that had severe COVID progression. I think this is an area of interest, both Paxlovid for prevention, but also I think there's a lot of interest in deploying Paxlovid in clinical trials for long COVID as well, those that are already suffering from it, particularly since viral reservoir is one of the leading theories right now. I know in speaking with other infectious disease physicians, there's concern that these antivirals really work best in active replication. So if you have this quiescent viral replication, whether or not treating with Paxlovid during the long COVID phase, whether it will truly be beneficial or not, we'll have to see how that comes out in the clinical trials.
Yeah, there was a little bit of discussion too about whether vaccination would help people with long COVID. How about any role for steroids in treatment?
So there have been some anecdotal reports of steroids, and in some patients they improve over time. Some patients actually get worse over time. I think it's really going to be dependent on the phenotype. There aren't really good data published on steroids and long COVID, but I think it will really kind of depend on what's going on, especially if this is underlying parenchymal issues. So we do see, especially alpha, delta, more organizing pneumonias. Of course, those are going to respond to the steroids, and potentially if there is some autoimmunity, but I think it will ultimately depend on defining those phenotypes better.
And are there populations at greater risk of long COVID or less risk? Like, does vaccination play a role pre-COVID? How about diabetics or people with other underlying diseases?
Yeah, so there's actually some studies showing that vaccination improves your risk, and then some that shows that it worsens your risk. And that's what we see anecdotally in clinic as well. Some people are saying, oh man, I got so much worse with vaccination that already have COVID, or I had a vaccination and still got long COVID. So again, I'm really curious to know the underlying physiology of that and whether or not there are certain phenotypes that it will be protective in and some that it won't. And then the next question was, what was the next question? Underlying comorbidities. Yeah, so there's a number of earlier studies showing higher risk of long COVID in some of the more traditional risk factors of, diabetes, obesity, hypertension, but those weren't done robustly with multivariable analysis. And when you control for other factors, really nothing is coming out yet. I do think that we'll get better data from Recover with meta-cohort data. All these studies are really quite small. But again, it would be quite concerning if nothing is showing, because the majority of the population do not have underlying conditions. I think as physicians, we tend to see those patients so much more, but we forget that the majority of the population are really quite healthy. And if those are all quite eligible for or vulnerable for developing long COVID, it's just a large population that is going to have a new disease they didn't have previously.
Dr. Johnson's getting a question that's similar to one that I had, so I'm going to package them both together. Are you seeing any of the patients who present that look like they have PASC, and that you either look back at who did not have known SARS-CoV-2 infection and you determined that they did, so they had asymptomatic infection? Because I'm very curious about the fact that those with mild illness are not spared this at all and may have greater risk. Or, as Ted is asking, or that you can't demonstrate prior SARS-CoV-2 infection but look like they have PASC.
Yeah, I mean, that's quite common, especially in these folks that had their infection in March. There are some data to show that comparing Delta to Omicron, there's higher rates of PASC in Delta to Omicron. I don't think there was Alpha compared to Delta to Omicron, but you can imagine it was such a severe disease with Alpha that there's a substantial number of patients who were not tested, there wasn't testing capacity for in March, that absolutely have PASC. And so we treat them the same way. And in fact, the Recover Initiative has been convinced by patient advocates to treat them the same way as well. I think, again, it's a heterogeneous and vague disease, but we definitely see constellations of symptoms that look like a PASC patient, and we're able to treat them the same way. So we don't discount patients that we can't corroborate their SARS-CoV-2 infection. And of course, as you know, antibodies can wane over time. So being able to, test for SARS-CoV-2 antibody exposure is not particularly helpful either, although that is being investigated by Recover. So it can be quite challenging, but I wouldn't discount someone that doesn't have a test.
And I'm curious too about, do you feel that there are I realize the study's not done, but do you feel there are commonalities, or that this may provide some insight into patients with post-EBV syndromes or post-Lyme syndromes? Yeah, absolutely.
I think I've kind of been, I've learned a lot about myself as a physician through this experience, because I think that I tended to discount some of those diseases previously, and I definitely see a fair amount of overlap. And I think it's important to learn from that experience. So I think that long COVID may provide an opportunity for us to learn a lot more about these post-viral, post-infectious diseases that are causing chronic symptoms in patients. We might learn more about the pathophysiology and the natural history of those diseases. So that's the one silver lining I've seen from this this pandemic, because I'm a believer now that there's a fair amount of overlap between the two. There's other folks that believe that viral reactivation may play a role in long COVID, that it's not the persistent viral reservoir of SARS-CoV-2, but that you have immunosenescence following the acute COVID infection, and then you have reactivation of HSV, EBV, and those are being investigated as well by large studies. So we may see that that plays a role, or whether it truly is the SARS-CoV-2, or maybe there's an interplay between the two. But I'm hoping that this provides us an opportunity to learn more about those diseases. And I do think we potentially had an opportunity as a scientific community previously to learn from them. And we could have been much further along in long COVID, assuming that there is an overlap.
Yeah, no, I think you made a lot of really good points there, and the sort of stigmatizing nature of some of those other illnesses that lost us an opportunity. There's also similarities, I think, to HIV and prolonged immune activation and so on as well. How about cluster one with more acute GI symptoms that where their symptoms seem to resolve more than in some of the other clusters you described? Do they have a better prognosis and less long COVID?
Yeah, so I guess that's one of the challenges of cluster analyses. If you've done them before, a lot of times it's just a model seeing association between symptoms, and it's somewhat of a fishing expedition, and you can get some important information from them, but then you have to take a clinical context to it. So GI fell into that category, but we absolutely see that some patients with GI symptoms later in their course, and they're not resolving over time. So one caveat to explain there. And they can be associated just the same with, also ME/CFS population. That's a common manifestation along with the pain syndromes you can see in ME/CFS. So, but I think some of those other symptoms that really stand out, the fevers and the cough. I mean, I should say cough can be persistent as well, but some of those other acute viral symptoms, they seem to resolve pretty quickly. GI, I wouldn't necessarily put in that bucket, although I would mention it's not the most common symptom that I've seen. Similarly to that meta-analysis I showed, I think those are the more common symptoms.
As Dr. Manning just put in the chat, this is a masterclass in doing Q&A and getting through a lot of answers with some really clear and concise answers. If I can keep you for a couple more, it'd be great.
Sure.
So Dr. Lam is asking, since there are many symptoms that are similar to sleep apnea, curious if sleep studies should be part of the initial workup as well. And is there any data about the incidence of new diagnoses of sleep apnea post-COVID?
Yeah, so that's definitely an interest of some of the large studies going on right now. So hopefully we'll have more data on that. I think it's still quite reasonable to screen for those patients, either the stop bang or the Epworth score. So yeah, some of these patients are waking up multiple times a night. And they're very unrefreshed. I've always had the question of whether all of this brain fog and fatigue is just related to that poor sleep as well. I think that's probably not fully explaining some of these symptoms, especially with the post-exertional malaise, where you can wake up and you can feel okay, even if you're not fully refreshed from your sleep, but then crushing fatigue after, again, like a cognitive load or a physical load. So I think there's more going on than just sleep disturbances in some of the symptoms. But I think it would be reasonable if your patient has a positive Epworth to refer them for sleep study. We'll have more data on that in the next probably year.
Awesome. And then last comment that I'm curious your comments on from Dr. Rimland. He said, I'm concerned that a very common infection with multiple phenotypes will make it very difficult to study pathogenesis and management. I see a big problem with ascertainment bias in the prospective cohorts. What are your thoughts?
Yeah, I think that's something we're struggling with right now, even trying to define these phenotypes, because that will ultimately play a role in investigating the pathophysiology as the current studies are set up. Once we define these phenotypes, then certain studies will be conducted in each individual phenotype. And yeah, it's been really challenging because, as I mentioned before, you could have brain fog and fatigue with dyspnea, or you can have it without dyspnea, but with tachycardia. And I do have concerns about that. It may be that we can't approach it through a phenotype approach, and we may need to just be looking into different pathophysiologic mechanisms and then treat based on pathophysiologic mechanisms and see how that has impact on phenotypes. But particularly since even within a symptom strata like dyspnea, you can have multiple perceptions of that dyspnea. Or even with the fatigue, post-exertional malaise versus fatigue, those might be different as well.
Yeah, no, great points. Actually, last question, online tests for brain fog to be used as a screening tool. Is that the DSST or?
Yeah, that's what we use in our clinic. If you don't have time for that, I can understand. Our long COVID visits are really quite long and very difficult to do for a primary care physician. I think if you're picking up brain fog in these patients, I guess I mentioned you should probably screen for this, but the digit symbol substitution test you could find online as a screening tool. That one you could probably integrate, and it takes about 90 seconds to do. But if you are picking up brain fog in these folks, you can also refer them to neuropsych testing. So in the Emory system, Alex Trung and Advik Dixit are the primary post-COVID clinic physicians. They're Plum Critical Care. They tend to refer their neuropsych patients to Michelle Haddad, and their POTS patients to Alexis Cutchins in cardiology for tilt table and investigation.
Thank you so much. This was we're over time, but this was an absolutely fantastic talk, and appreciate you spending time with us today. And for everyone else, also happy holidays. And I hope everyone gets some downtime in the next couple of weeks.
Great. Thanks everybody for the opportunity.
Thank you.